Welcome, everyone, and thank you for joining us. My name is Molly Blau-Gillis, and I'm Chief Communications Officer at General Catalyst. We're so glad you're here for the second installment of our Conversation Catalyst speaker series. Before we begin, I wanted to take a moment to acknowledge that our thoughts and prayers are with the people in the Ukraine, wishing them safety, including our portfolio companies, limited partners, their teams, extended families, and friends. We're all watching and hoping that peace can be restored as soon as possible. GC created the Conversation Catalyst to feature unique perspectives, insight, and leadership from GC, our portfolio, our community, and beyond, focused on topics that are core to our mission of investing in powerful, positive change that endures, including responsible innovation, health assurance, and economic access, to name a few. In today's conversation, GC Managing Director Chris Bischoff will moderate a panel discussion among leaders in our healthcare portfolio and beyond who are working to transform healthcare from a sick care system to a resilient, proactive health assurance system designed to help people stay well, bend the cost curve through innovation, and make quality care more affordable and more accessible to all. Our Conversation Catalyst series will continue in early April with a discussion focused on responsible innovation, where we will be joined by internet pioneers Bob Kahn and Vince Cerf, who will share their unique experience and perspective on innovating with intention and avoiding unintended consequences. More information and registration can be found in the chat on the GC Amplified section of our website and on our social channels. A few housekeeping items. As a reminder, this session is being recorded. Closed captioning as well as a live transcript are available for those who are interested. If anything should happen during the Zoom session, please immediately log back into the meeting and we will proceed. And now it's my great pleasure to introduce my partner, the incredible Chris Bischoff. Chris joined GC a little over a year ago as our first managing director based in London. He leads GC's global healthcare investment practice, responsible for delivering on the promise of health assurance. Chris has led investments in category-defining companies, including AIDoc, Avito, Babylon Health, Betterment, Cedar, Cityblock, Devoted Health, Livongo, Sword Health, Overjet, and Village MD. Chris, thanks so much for leading our discussion today. I'm going to hand it off to you to formally introduce our panel.
Thank you, Molly. Great to be here. Welcome, everyone. We're here to talk about the next chapter of making health assurance a reality. As Molly mentioned, health assurance is our thesis of making care more proactive, more accessible, more personal, but also more affordable and efficient. The pandemic that we've just been through exposed deep vulnerabilities in the healthcare system, but it also demonstrated the extraordinary power of technology and innovation to transform healthcare and proved that the health sector could accept change when faced with such a crisis. Now that the pandemic is becoming endemic, we believe it is time to reset our intentions on the long-term reinvention of healthcare. And we want to build on the momentum achieved and deliver on our ambition to reduce healthcare expenses by hundreds of billions of dollars by 2030. Today, we're going to talk about two of the biggest issues in healthcare, equity and value. But before getting into it, as Molly mentioned, I wanted to introduce our distinguished panelists. Dr. Jennifer Schneider is an XAR at GC and serves as an independent board director at a number of portfolio companies, including Cityblock Health, Sword, and Jasper Health. Most recently, Dr. Schneider served as CMO and president of Livongo Health, where she oversaw the strategic, technical, and clinical direction of the company. Prior to that, she was chief medical officer at Castlight. Dr. Toyin Ajayi is currently the co-founder and president of Cityblock Health. This is a New York-based healthcare company radically improving community health in urban areas. Prior to Cityblock, Toyin served as the chief medical officer of Commonwealth Care Alliance, a nationally renowned integrated health plan and care delivery system for individuals duly eligible for Medicare and Medicaid. Dr. Bruce Meyer is president of Jefferson Health and the senior executive vice president of Thomas Jefferson University. As Jefferson Health's clinical leader, Dr. Meyer is overseeing its transformation into a single integrated system that delivers safe, reliable, and high-quality patient care at every Jefferson practice, regardless of its location, size, or care type. He's deeply committed to continuous improvement and the pursuit of excellence in healthcare, including the need to decrease total cost of care. Othman Laraki is the co-founder and chief executive of Color, a health technology company that works with governments, with public health institutions, employers, and national health initiatives around the world to provide the tools for preventative health and infectious disease management, including testing, vaccination, and other services. Prior to Color, Othman was a successful entrepreneur with several years in leading roles at Google and Twitter. So welcome to our panelists. The first topic I want to talk about is access and equity. And maybe we start with you, Toyin. Can you start talking about these two elements of healthcare transformation, where we stand on access, where we stand on equity from your perspectives, how they're related, and how each can actually drive cost savings rather than increasing incremental demand and cost?
Absolutely. Thank you so much. And thank you for the invitation to be on this panel. It's really tremendous. Just very briefly on Cityblock Health and the perspective that we take on this work. Cityblock is a care delivery organization focused on folks with the most complex needs in the healthcare ecosystem, primarily people who receive their insurance through Medicaid or who are dually eligible for Medicare and Medicaid. We provide primary care, mental health, and social services, really anchored in trusted relationships in those communities that are often the most left behind with healthcare innovation and technology. And so we're sort of at the front lines of seeing where the challenges around access and equity intersect. First and foremost, I think recognizing that that while we have some of the most tremendous technology healthcare innovations across this country, these are not equally distributed. And so the communities in which people, like the folks whom we serve at Cityblock, the zip codes where people are more likely to experience lack of access, not just to healthcare, but also to safe and affordable housing, to food that's healthy and nutritious, to transportation that's affordable, to green spaces in which to exercise and walk around. These are exactly the same places that also have a dearth of access to primary care and mental health. And so when we think about the opportunity to your point, Chris, to improve access and also to reduce spend, it's primarily by focusing on those services I described, because primary care and mental health and social services are the bedrock of our preventive healthcare system that can result in, if effectively deployed, result in a much significant sort of transfer of healthcare spend from hospitals, which are reactive, often high cost, often actually do not fix the underlying problem, to the community where we can actually deliver services that will meaningfully change the trajectory for people. And so by bringing care into those communities, meeting people where they are in their homes, in community centers, in our hubs, we're able to shift that dynamic and meaningfully invest upfront in the types of services that change outcomes. When you layer that on with the equity question, no surprise here, given the history of this country and of our systems, that the exact same divides and divisions that result in poor access into health services in lower income communities are the exact same fault lines that reflect disparities by race, by ethnicity, by language spoken, by disability status, by access to a whole host of other social services that precede but reinforce all of the disparities that we see in our systems. And so by focusing in on these zip codes and these communities, by bringing the types of care that we're describing into these communities, you can achieve both an improvement in access and a reduction in cost, while also changing and moving the needle on equity, starting to reinvest in places where, in communities and populations that didn't otherwise have the services that they needed to receive better outcomes.
Thank you, Toyin. And Bruce, you operate a health system, that operates in, some parts of Philadelphia amongst the poorer parts of the nation. You're a health system. How do you, to Toyin's point, she's advocating for primary care-led model as a hospital system. How do you deliver equity and access?
Sure. So I think the challenge for us is that access, as we historically defined it, was how easily can you find your way to a bricks and mortar building that we operated. And I think access, even through the pandemic, but certainly going forward, has to be defined as how do we touch you in a place where you are, and how do we reach you where you are in a way that is effective for the kind of care you need to receive. So Some of that's technology enabled, some of that's sort of digital front and back door pieces. We are challenged particularly in neighborhoods that Dr. Ajayi talked about, where digital divide is a real problem for us. You may have a smartphone, but you don't have a data plan that allows you to do a telehealth visit. That's a problem if we've pushed all our, front-facing work into telehealth kind of things. So I think part of it is, how do we overcome those kinds of technology barriers while using technology to enhance the kind of care and the access to care where you want it, where you need it, and when you need it. I talk to my folks all the time about, some care has to have an address. There's stuff we have to bring you to a place to do things. But an enormous amount of care doesn't require a specific address. It requires our ability to reach out and be where you, the individual or the family, are. And that's the challenge for us, is how do we find the ways to reach all those people effectively enough? So we've pushed a lot of effort and time into the technology piece, into the virtual visit structure, into, as an example, we're doing about 80% of our behavioral health work in virtual spaces. Some of it's in person, because some of it has to be in person, but the bulk of it's in a virtual way. And we're doing things like supplying people with data plans and giving people devices sometimes, because that's what we need. But it also means that we have to do physical outreach. We have a lot of homeless folks, doing a virtual visit for, making virtual visits universally available doesn't do much for the homeless who don't have a way to access that kind of technology. So it is actually getting onto the street with community healthcare workers that know people and are, it's working with the EMTs who bring people to the hospital repetitively and say, because they know those people by first name typically. It's how do we work with them to say, let's provide care in that apartment, in that home, in that neighborhood, that avoids you having to call an ambulance to bring you to a hospital, where we provide very costly, mostly inefficient. If you are acutely ill, you're shot, stabbed, you're burnt, you're in a car wreck, those kinds of things, we're fantastic at that, right? But for an awful lot of stuff, it's mostly about preventive medicine and about reaching you where you are and about finding ways to improve the quality of your life. Sometimes that's helping people get a better job and things like that. That's the best thing we can do for your healthcare. Food security is oftentimes the very best thing we can do for healthcare. And we have a huge program around food security with local organizations like Philabundance and in an effort to bring meals to people rather than saying, hey, here's a voucher that you can get a meal.
Got it. Both of you, I think, have stressed that it's not just a question of access, but it's a question of engagement. And Jenny, I know you're spending a lot of time thinking about rural health and where that sits today as part of the healthcare system. And obviously, some of the issues of access and quality are most acute there. And I also know that you've come from a small town in Minnesota. So how are you thinking about the changes that need to happen or the problems to solve for rural communities?
Yeah, Chris, thanks for the question, and thanks again for the opportunity to be with all of you distinguished folks here. Many of you might or might not know, but 1 out of every 5 Americans lives in what's deemed as a rural health area. And that's defined as a territory with less than 2,500 people. And when you start to look at healthcare in rural markets, in rural areas, it's very different. So there's a 23% higher mortality if you live in a rural area. That is shocking. That is sort of the equivalent to what happens relative to the United States as a whole compared to Tanzania. So we're talking a very, very different level of outcome. When you look at what the access is like in rural markets, in the last 10 years, 130 hospitals have closed. This has been accelerated with the stress of COVID, both from the economic side as well as the provider burnout. And 40% of rural healthcare hospitals are expected to be at risk for closure within the next 5 years. So this is not going away. And as we start to think about what it is that we can do and deliver, we really need to invest in more of those extensions, those enhancers, to be able to get care into the community. Both Toyin and Bruce talked about that. Building on the backs of the local community, what's invested, get to understand people. One of the things that we did at Livongo was spend a lot of time in really personalizing the message, and that includes inviting people into the service. So understanding that in order to achieve access, in order to achieve equity, we have to understand people for who they are, and that often involves really tight coordination with local community. Chris mentioned I am from a small hometown in rural Minnesota, and so these messages, the relationships that are dependent and built in order to provide successful care, ring very true to me.
Thank you, Jenny. And, when we talk about access, Othman, your company, Color, has done a terrific job during the pandemic in terms of building out COVID testing sites and vaccine sites, or empowering COVID testing sites and vaccine sites across the country. Can you talk a little bit about your journey and how you've driven greater access?
Sorry, I just realized I was muted. Sure, that sounds great, and very much, I think, echoing the experiences and insights from the other three co-panelists. But I think one of the interesting, I think, realizations over time has, and even it actually predated the work we're doing through the pandemic earlier on prevention as well. But which is, I think, one thing that's always been striking to us has been that everyone wants to be healthier. Everyone wants to do the right thing for their own health and their families. And it's oftentimes not a question of, awareness as much or will, but really a question of like, how do you make it possible for healthcare to show up in the context of people's lives? And I think the more you get closer to more underprivileged members of our society and rural folks and so on, the more acute I think that impact is. And the easiest way to make people do anything, we found, is to increase immediacy and reduce the transaction cost. And by transaction cost, it's not the financial cost that's oftentimes the biggest hurdle, but much more the like life hurdle, where 60% of Americans are hourly workers. If you ask someone to take the time to find a doctor, do the research, schedule it, take a bus to get there, bus to get back, wait while they're there, for something that in reality should be a lightweight transaction, a simple transaction, those are the things that oftentimes get delayed and get pushed back. To Dr. Meyer's point earlier, for example, if you have an acute problem, if you break a leg, it's no longer on your terms, you're going to show up to the hospital. It's when there's all of the other things that you should be doing and you want to be doing, but that compete with, going to work, taking care of your kids and so on. Those are the things that oftentimes are the victims in some sense of the access challenges. And what we found at Color that's been, I think, one of the most impactful things we've done is that we've taken, in reality, what should be simple services and enabled them to be delivered in a simple way in communities. And that's, for example, so right now we power about 10,000 sites across the US, not just within COVID, but also on the prevention side. And these are workplaces, churches, schools, prison systems, senior centers, and so on. And the thing we've done that I think has turned out to be really valuable is to almost like decouple this kind of notion of the heavy health system from providing basic access, and to build a set of tools and logistics so that you can run a vaccine site or a testing site that is community powered. So for example, we run a lot of work with a coalition of Black churches in California with the state of California. And it is all entirely community based, right? Where the people who are running the sites mostly are actually part of the community. We can supplement with either our own staff or contract staffing. But what we found is that, when you provide the tools and the infrastructure so that communities can effectively self-serve, there's actually a lot of healthcare that can be delivered without heavy healthcare infrastructure. And so taking these basic services into where people's lives actually are happening, right? Like where your kids go to school, where you go to church, where you go to work and so on, that's where life happens. Allowing that self-service model that makes it possible to really kind of have a very big footprint. And then having a transactional relationship where as an individual, you don't need to jump through a bunch of hoops, like, finding a doctor, going through complex scheduling, dealing with payments, like even when healthcare services are covered, oftentimes it's actually the transactional overhead of figuring out, like, is your insurance going to pay for it, dealing with co-pays and all these things that also each point of friction causes access, costs access. And so we build this model that really just strips all of that out and we enable simple things to remain simple. Again, like there's a complicated and hard side of healthcare, in some sense, hard with a big H, that, I think, that we actually have, I think, a really good system for. And I think where we found a lot of value is to figure out the set of services that really should be very lightweight and enable them to remain that way. And so that's been for us like one of the things that's had the biggest impact in the communities that we work with.
Thank you. I'm hearing that we need to make healthcare more distributed, right? Put it into the communities, more connected, more personalized by condition, race, demographic, geography, and clearly more inclusive. And I think you're saying that it's not just an access question, or access is beyond access. It's the friction in the system, and this challenge of getting engagement, the challenge of treating patients with dignity and empathy to make sure that they utilize the care. So that, look, I think has been very helpful, and we've got different perspectives from different parties in different parts of the healthcare ecosystem. I wanted to transition now to talking about value. And, I think, one of the challenges during that has been with our system that was highlighted during the COVID pandemic is clearly the fee-for-service model struggled to really succeed in that in that time. And when we look at the future, we talk a lot about value-based care, outcome-based measurements. What is required beyond access and equity to deliver value-based care as we go around the table and think about these various constituents? So, maybe again, starting with you, Toyin, how do you transform access and equity into value?
Awesome. Yeah, I know. I think building on the prior sort of round, the first thing is we have to define what value means, right? And what are the outcomes that we're looking for? And that may differ slightly by stakeholder, but ultimately what we're talking about is, do we get meaningful outcomes for the investment that we've placed in the healthcare system? And today, as you said, Chris, the answer is absolutely not, right? Like, when I think about the populations that we serve, we're talking about folks who receive their healthcare through government-funded insurance. It's $1.5 trillion worth of investment to receive the types of outcomes that Jenny framed up in terms of not only absolute, life expectancy, mortality, but also the gaps between those who are at the far end of getting, I think, a lot more value for their money, and those who like the folks we serve, who do not. But we also have to ask what matters to the patients whom we serve, and what value are they receiving? And I think to Othman's point, if you're asking a person to take a day off work, that's cash out of their pocket that would have been income, pay for transportation to go to a clinic, find someone to watch their kids, wait for an hour when their time, in many ways, for many people, is their sort of greatest asset, to receive historically 10 minutes of time from a clinician, most of which they don't feel that the person's actually listening to them or cares about them, then we've not delivered value to them either, right? And so we think about those two sort of vectors. If you think about the patient and the member experience and what they value, because that's a key input into engagement and their attention. And then you think about the economic value to the healthcare system, to the payer. in order to deliver on both those dimensions, you have to actually redesign the entire healthcare system, we're finding, because the traditional way that we provide care, that sort of rigmarole that we ask people to go through to come to us, in Jenny's case, it's drive hundreds of miles to get there. In my case, in urban centers in this country, it's public transportation, it's cost, it's all of the friction associated with that. That is not working. And so people default to the emergency room, because at a minimum, that is the one place in the healthcare system, or frankly in our society as a whole, where if you show up day or night on terms and timing that is convenient to you, there is someone who's obligated to pay attention to your need, even for that minute. And that need may be a warm, safe place to sleep and a sandwich. It may actually not even be a medical need, but we do this at an immense cost to the healthcare system. And so what we've had to do is really reorient and redesign care, bring care to people on their terms and times and locations that are convenient to them, build out the relationships so that we're even asking the question about what they value. How would you like to spend your time? Who do you want to be talking with? What matters to you? What does health mean to you? If we start by focusing on those issues and factors from the perspective of the patient, then we earn the right to talk about the medical and the behavioral health and all of the other layers and dimensions that they need. And then we actually have to deliver against those care needs in a way, again, that is responsive to the lived reality and experiences of these patients, which means that telling a person in psychiatric crisis that they have to wait 6 weeks for an appointment with a therapist, and they better remember to reconfirm that appointment the morning of, otherwise it will get canceled, does not work. That's not care for mental health. Care for mental health is a warm handoff at the point that you need it to the provider who's going to care for you as part of an integrated team. And the recognition that if you have physical health challenges that coexist with your mental health challenges, that coexist with your social challenges, each one of them matters. And if you're challenged with taking your diabetes meds, it's actually you don't have enough food to eat on a regular basis, we have to solve for that too. And again, the sort of beauty of this work, for me anyway, in the value-based care setting, particularly for people with the most complex needs, is that ultimately doing the right thing for the patient is also the right thing for the economics of your business. If you can do all the things we described, build engagement, build relationships of trust that dignify and respect the people you serve, deliver care when they need it, how they need it, in places that are more convenient to them as an alternative to the emergency room, you can shift care from expensive places and get way more value for the investment in healthcare that we're delivering than that we're providing, as well as providing an experience of care that people really value and cherish.
Thank you. And Bruce, when you look back at value-based care as a concept, it's been around for a long time. CMMI has invested tens of billions in it, but ultimately to date, the savings haven't been huge, certainly from the traditional healthcare system. And to some degree, the impetus for value-based care is coming from private sector actors, primary care and increasingly specialty care businesses that are taking on risk themselves rather than the healthcare systems. Why has there been this challenge to drive value-based care into health systems? And what at Jefferson are you doing to make it more of a reality?
Yeah, I think the major challenge is that the way we pay for healthcare in the United States creates a perverse incentive. The perverse incentive is the more you do to somebody, the better you get paid. Although there's lots of discussion about the fact that surgeons and proceduralists were all at the table when the RVU system was created, and there were no people who were E&M coders, whether you're primary, I loosely define primary care. It's not just sort of family medicine and primary care internal medicine. It's behavioral health, it's neurology, general neurology, it's women and children's care. Those are all primary care kinds of functions for us. And so what's happened is the RVU system and the payment structure around fee-for-service drives behaviors that are perverse. I mean, no provider comes to the office today saying, I'd like to do a mediocre job for my patients. And if I only see everybody every 6 minutes, I can drive a gigantic amount of revenue in my office. However, what we get out of that kind of perverse incentive is if I do more widgets, I get more money. And if I do a lot more widgets, I it's a lot easier to do widgets in a mediocre way than it is in a high quality, truly personalized way for every individual. And so what we've got to do, and this is what we've really started at Jefferson, is two large things. One is move away from the RVU-based payment system, where doctors look at it as the more stuff I do to people, the better I do. So it's much more a base salary structure with an incentive around experience of care and of outcomes of care. And Toyin is right around how do we define quality, and how do we find value becomes really important. And we don't have a really perfect way to do that, but we're working at it. So it's about patient-facing time, and whether that patient-facing time is in a virtual environment or in a physical environment doesn't matter to us. But it can't be about how many, if I just get my average visit time down to 8 minutes, I will, fulfill volumes and get a giant incentive. So we've moved away from that. I think the other thing is that I think is really critical is I love my primary care colleagues, but folks have to specialize as a primary care doctor. It is ludicrous to say that I'm going to see a Medicare Advantage patient, a managed Medicaid patient, a traditional Medicaid patient, a commercial patient on a value-based program, and I'm going to hop from room to room to room to room and try to understand what each of them needs in the perverse system of incentive we've created.
Right.
It's got to be, look, 80% of the patients I see are dual eligibles. 80% of the patients I see are Medicaid. 80% of the patients I see are commercial value-based patients. And then we can create a structure where we actually provide value to those patients. And we don't create an incentive that says that every visit, the smaller the time period for every visit is, the better off you do. We've got to move away from that. And that's where taking full risk of care is the critical part of it. If you own the entire dollar, you're inside the full premium dollar, then it no longer matters to you. In fact, you're happier if you're doing less stuff to people and you're doing more preventive work because the total cost of care goes down. And so what we've tried to do is to move our organization toward that. We're taking full risk. We're not just getting a little bit of upside from a payer, but we're actually like we own the whole dollar. And if we do badly with that dollar, then we have to pay out of pocket. So about 30% of our care right now, admittedly, we'd like it to be 100, but 30% of our care is full risk care. We're actually at the weird bleeding edge of health systems at that level.
Right.
In this country. We need to get to 50. We need to get to 70. But until we get away from the perverse incentives of we pay per widget that is put through the system, it gets real hard to change the system, because when your income depends on a certain behavior, it's really, really hard to get people to change behavior.
Makes total sense. And I know you've done some structural things like integrating as a payer and provider to achieve that end. Jenny, as you think about rural health, is there a fee-for-service model that can work in rural health? And as you think around what needs to get done, can it be built on a chassis that combines fee-for-service and value-based, or do you need to build on a chassis that is either one or the other, a little bit to Bruce's point?
Yeah, thanks for the question. And I really like where Bruce started, which is the reason fee-for-service doesn't work is we have misaligned economic incentives. So we have to align economic incentives and member or patient preferences to achieve optimal outcomes. In rural markets compared to urban markets, there's a big differentiation in specialty care. So in an urban market has 8 times more specialists than in rural markets. 8 times. We know that primary care docs, and I'm an internal medicine doc, we account for on average 12% of total costs. That other 88% are specialists. So rural markets, I think, are really hurting in terms of being able to provide optimal outcomes, both cost-effective clinical outcomes and experience. And I agree with Toyin that in order to change to a value-based care delivery system, you have to re-architect what's in existence. You have to kind of put somebody in control to figure out the solutions downstream, to align economic incentives, to drive clinical outcomes. So I have a belief that in rural markets, the real transformation starts with a change in the economic model, and then the evolution, the tools, the technology that we've seen being developed will then allow that downstream delivery system to achieve the ultimate goal.
Understood. And Othman, when we've spoken in the past, you've highlighted the fact that, in your mind at least, a value-based model with all the complexity of judging value and coding and the room for perverse incentives, even in value-based models, may not always be the right model for healthcare. Subscription models, other models can deliver the outcomes you want. So rather than focusing on payment models, you focused on other areas. Do you want to touch on some of your thinking in this area?
Sure. Yeah, I guess I'm a bit of a contrarian relative to kind of common belief today, I think, which is that I wonder whether in reality it's going to turn out that the value-based fee-for-service divide is a bit of a red herring, because in reality, I think what we've done in some ways, and sometimes words and meaning overlap only partially. And when we call this thing value-based care, I think we actually make a different attribution. Whereas in reality, when we say value-based care today, and the way it's generally defined is that it has primarily been around the notion of saving, the goal of reducing the cost of care, as opposed to truly solving the market problem. And in my view, I think whether it's fee-for-service or value-based model, if you have a broken market, you don't get value. It is a functioning and competitive market that provides value. And an example I'd kind of shared in a prior call was for example, we are all consumers of Amazon, Uber, Airbnb. These are all incredible services that we tend to be very happy with. And they are all fee-for-service services, like all of the best services in general that we experience in our lives that deliver the most value to us as consumers tend to be actually fee-for-service services where we pay for something and we get something we really like for it. And I think with healthcare, I think we've wrapped ourselves a bit around this axle that thinking that it's purely an incentive problem, that it's okay if doctors are paid for transactions, they're just going to maximize transactions and overuse the system. And if you pay them for, value by capitating and putting their skin in the game, they're going to magically change their behavior to really orient around giving us more value. Whereas I think in reality, I think the biggest challenge is almost that transactional efficiency, where we have a system that makes it impossible for doctors, whether they're incentivized for transactions or for capitation, to have an efficient relationship with you. And we burden doctors as well as patients, I think, with, whether it's even simple things like prescribing birth control or getting vaccines to people and so on, with this incredibly frictionful payment and transaction model that makes it difficult to actually give you a good value. And so I think in reality, I think it's kind of separating a few concepts, right? Like as a society, what percentage of our GDP do we want to allocate to healthcare? Today it is higher than all of us want it to be, granted. But I think a much bigger problem is that we're not getting the value for what we're paying. It's a much bigger problem. And that's why the costs have been continuing to escalate, is because we're trying to chase the outcomes that we're not getting for the money we're putting in. And I think that's much less an incentive problem and much more an investment in increasing the transactional efficiency. When I look at how technology, for example, has impacted all of different slices of our lives over the last 20 years, whether it's like watching movies on Netflix, listening to music on Spotify, Uber rides, et cetera, it has all been around transactional efficiency and simplifying access models. And that has been consistently the biggest lift in the value we are getting as consumers. And I think that in my eyes, that is the biggest opportunity. I think the incentive side is more of a, really what are you paying for? What's the price tag in the exchange made for? Is it for transactions or for, like an alignment of outcomes? I think you can actually get great value in both of those. And so as a company, for example, with Color, we work on both sides of the field, and we're completely not like, and what we really focus on is no matter how we are paid or how the service, the incentive of the provider we're working with, it is primarily about like, reducing that transaction cost. Like literally, if someone does not need a doctor's appointment to get something done, like, for someone to renew a thyroid medication, or for someone to get birth control, or for someone, et cetera, there's a lot of these situations where if we are focusing on reducing that transaction cost, like I think one of the challenges too is like the minimal transaction that we have with a doctor today is a doctor's visit in general. And I think departing from that, where it's like when we kind of come to the notion of like, there are big parts of healthcare where you don't need re-adjudication for every person for a simple, decision. How do you, if that's the case, how do we embrace this notion of dramatically opening access to basic services, to turning it into more of an algorithmic approach, to reducing kind of like the payment friction and so on? I think these are, in my eyes, the some of the biggest, challenges. Again, it doesn't solve the acute care side. I think, the incentive to do more knee surgeries and we need to, and things like that, that is I think in my eyes, a separate problem. So I think that's where kind of this incentive divide, I think, becomes much more pertinent. But for essential basic care, I think it's an 80% on the competitive transactional model problem as opposed to an incentive issue.
From the panelists, any perspectives on Othman's comments there that you want to share, or we move on?
I might make one comment, and it's a little orthogonal to Othman, but sitting as an executive in residence at General Catalyst, VBC, value-based care, is definitely like the new hot buzzword, where AI was before and cloud was before that. And the reason I bring that up is I recently had a chance to interview Troy Brennan at CVS, and Troy made the comment, and I think it's worth hearing and talking about, particularly to the listeners here, which is, value-based care it's really only something if you're really doing total capitation. I think Bruce alluded to this, at 30% of their business. And so these concepts of value-based care, to say, well, I got 70% of people engaged, therefore that's value. That's a performance guarantee construct, and that word is used very, very broadly. And I think what this group here is talking about is really more that total capitation, the total payment model in terms of value-based care.
Yeah, and I would just,
absolutely.
I'm sorry if I could, Chris. I think your comments are really interesting, Othman. I think we have to separate, though, the point solutions and specific units of service delivery, which I think are incredibly important, and where I think a more kind of consumerist approach to market forces makes sense, from what Jenny's talking about, which is total capitation, total cost of care. Because you started your comments by talking about sort of a market that doesn't function. As we know, there's lots of reasons for market failure, and all of them are at play here in healthcare, including information asymmetry, which is a major one here, right? So you cannot expect your patients, who are consumers of a seamless, frictionless experience of ordering birth control, to have the medical and the financial knowledge to contextualize how that intervention plays into true value from the perspective of the healthcare system. When you take that example and you layer it on to people like the folks we serve, who have the most complex problems in the healthcare ecosystem, who are struggling with, substance use challenges and mental health challenges and 4 or 5 chronic conditions, and are hungry, they cannot be discerning purchasers of each service that would be required to make them healthy, because we haven't created that ecosystem for healthcare. And so I think it's really important to say, that there is, that both can be true. When you're talking about specific services delivered, we have a lot to learn, and I think a lot to benefit from a consumerist approach to care delivery, which is to say, remove friction, delight the customer, deliver the thing as quickly as possible. That's great. However, how does it fit together to create healthier individuals, societies, communities, and lower cost to the system as a whole, that requires a whole other layer that we're describing as value-based care. To your point, Jenny, we should unpack the language, but that requires ultimately some, the key components of value-based care in my mind are, an understanding of the total trajectory, prediction of what's going to happen for people, some sort of coordination function that makes sure that we're deploying right care, right time, right place to the right person, measurement, and longitudinal accountability. And that has to exist even as we work to sort of transform the way that specific units of care are delivered. And so I think the answer is a bit of both. And perhaps we're talking a little bit past each other when we sort of use these big terms without sort of unpacking what they mean.
Yeah, if I can just, I'll piggyback and say, consumerism and the educated consumer is very different when it comes to healthcare, because for mostly worse in this country, we have done a fantastic job of trying to deny education to people about health and preventive care. And because we have done, and that creates a nice monopoly for providers, so we kind of enjoy that. But I get very nervous because and we've seen illustrations of that recently, where things like ivermectin were touted for COVID, and experts, and how do we define that? And so what happens then is that trust is eroded in terms of trusted communication, because we don't have an educated consumer, and it's really hard to figure out how to get educated as a consumer about what the best thing is. It becomes easier to make bad choices as a consumer. And then the consequences of those bad choices actually fall to both the society and to the individual. And I worry about that. I'm not sure that we're quite ready for it. Not that in the broadest sense of philosophical belief, I don't think it would be the right thing. I think it would be the right thing. I just think we have an enormous amount of disinformation, misinformation, and lack of education to allow a consumer to be really good at figuring out what is, do I really need this? Do I not need this? How do I, who should I talk to, et cetera? And I think one of the dangers we see of the polarization, especially in our society, is the erosion of trust of scientists and of, respected voices who have spent years and years and years getting themselves educated to be an expert in something. And then how does a consumer, differentiate between dueling experts in what the treatment of COVID is? We've seen that play out pretty profoundly in perverse ways. I literally had a conversation on a Zoom meeting with about 350 people where I said, please do not use Clorox to try to treat COVID, because that had been in the national press. So I worry a little bit of how do we make the transition to an educated consumer, and we see some of that even with Amazon to a degree, right? There are 3,000 reviews. How many of those are legitimate verified purchases? Well, Amazon is trying to tell you which one, and does that mean that they're a really legitimate reviewer that's going to help me inform? I try to translate that to healthcare, and it gets even more confusing.
Maybe if I can jump in, just one other, just kind of a response to the points here, because I think a few things are getting kind of conflated in this, which is that there's a separation between decisions from a policy standpoint of what are services that the medical establishment agrees are necessary and valuable to the community at large, and that we want to promote access for. Like, there are a lot of things where we have a dramatic underutilization problem, like fundamentally, right? Like, getting vaccines and access to testing, the biggest hurdle was underutilization. Getting mammographies, like, I have never met a woman who wants to overutilize mammographies, right? Colonoscopies, managing your cholesterol, right? Like, these are all things where there's a very broad consensus. The cost and risk of overutilization is minimal, even if it exists. And what more the point I was making on that is around one of the things that I think actually the COVID experience has been pretty eye-opening for a lot of folks, because it's the first time I think that we as a society have delivered basic health services in a completely like broad-based distributed way. I mean, like, you know, putting in perspective, right? Like, I think we've pulled off collectively, right? Like, you know, everyone here, and you know, that like I think in many ways, like a real, like there are many things that could have happened that to be better through COVID, but like it's been a miracle of, you know, operations and access. Like we've never done anything that had, like we've delivered billions of vaccines, we've done, you know, probably tens of billions of tests, right? And in a, you know, not completely equitably, but much more equitably than we have done in almost every other facet of healthcare. And I think one of the things that has really clicked through that is this kind of like orientation around transactional efficiency by saying, okay, this is something that is very simple, like in reality, right? And that we want to deliver to people in a highly accessible and simple way. And that kind of, I think that's more what I mean by like focusing on transactional efficiency. It doesn't mean like, you know, letting the patient go and decide like, you know, oh, here's, you know, the list of medications, I just want that and I get it. But much more saying like, okay, there's a set of protocols and a set of, you know, there's very high consensus around that we, you know, that are worth delivering to large populations. How do we do that in a completely transactionally efficient model? And so I think that's more the, and there, like, I think whether it's fee for service or value-based, I think is a bit of a, you know, you can pay for it either way, but I think it's much more that transactional efficiency it's less an incentive problem, but more a delivery model challenge sometimes with these things. So I agree with the points that you're making. Like, it's not like I think caring for the whole individual, et cetera, is I think definitely something that doesn't go away. It's more that like, it's not, I don't think it's purely saying, okay, if if one entity is on the hook for the entire, you know, dollar, that solves the problems, and that makes real value delivered. That's kind of, I think, but so in many ways, I agree with a lot of the points you're making. But it's more, I think, like, you know, maybe to Toyin's point, like, I think there's like the two sides to it that we can't ignore. And I think oftentimes I feel with the value-based kind of conversation, we've focused purely on incentives, but that's in my eyes, like, you know, only part of the equation.
No, I think
Great.
sorry, Chris, a final point, and then I'm sure you want to wrap us up, but I think it's a yes and, Othman, because I think to your point, like, operational efficiency and seamlessness is important, but absent like any accountable value-based structure, it's always going to be easier to go vaccinate the, you know, a millionth person who has a lot of resources on the Upper East Side than it is to vaccinate somebody in a rural town in Texas or in, you know, Crown Heights, New York. And so we get the inequities if we focus only on one at the expense of the other. We have to, it's a yes and, because the success that you describe in terms of this vaccination as an example is also a massive failure in terms of our ability to actually safeguard the health and well-being of everybody equitably, because there was no conductor of the orchestra. There was no sort of single accountable unit of measurement or of delivery across all of this to make sure that not only are we removing friction, we're also equitably distributing the emphasis and focus of service delivery across a set of populations. And so it has to be both. And I think the work that you're doing is remarkable, and the work that folks like you do that is remarkable in eliminating the friction so that we can actually execute. And also we have to think about that alignment of incentives. It's so important, because if we don't, we just continue to make things easier and better. Like all those companies you described up front, the Airbnb and the Amazon, they don't impact my patients' lives at all. So we can continue to make these things easier and better for the people who have, but we have to think about the ways that we're actually trickling this down or bubbling it up to have a much more broad-based impact across the healthcare ecosystem.
That's a great note to finish on. Thank you all for your insightful comments. It's been an active debate, which is what we like to see. And you're all making healthcare better in your own ways. And we appreciate being associated with you and partnering with you on your journey. So thank you again, and have a good day.